Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner. As a physician, I see death related to cigarette smoking every day. With all the other health threats in the world, the risks of smoking often don't make the front page. However, according to the CDC, cigarette smoking causes almost 500,000 deaths in the U.S. each year, more than motor vehicle accidents, firearms, alcohol, and illegal drug use combined. Once people start smoking, it can be difficult to stop, in large part because of the addictive nature of nicotine. Today, I have the pleasure of speaking with Brian Quigley. Brian is the CEO of Qnovia, a company with a unique approach to help people stop smoking. But before we get started, I'd like to thank our sponsor, locumstory.com. If you're considering locum tenens either full-time or on the side, you probably have a question or two, or 20. Fortunately, locumstory.com has the answers you need. It's packed with unbiased information and advice from physicians like you. Locumstory.com has nothing to sell. It's simply a resource for information. You'll find super handy tools that let you see locums trends for your specialty, compare different locums agencies, and there's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. And now, without further ado, I'd like to welcome Brian Quigley to the program. Brian, thanks for joining us.
Thanks, Dr. Wilner. It's a pleasure to be here.
Yeah, well, I'm thrilled. I learned about you and your company just a little bit. So why don't you fill us and tell us what your background is and how you're trying to change the world?
Sure. So Qnovia, we're a venture-backed pharmaceutical development company that's focused on developing a portfolio of inhaled therapeutics across a host of indication areas. And our lead asset is an application to FDA's Center for Drug Evaluation and Research to be the first inhalable prescription smoking cessation therapy. And which is kind of interesting. My background, actually, I spent 16 years as a business leader at one of the major US tobacco companies. And one of the things that, really I find is a shortcoming of innovation in medicine as it relates to the death and disease caused by smoking, as you referenced. It almost seems like we're numb to the fact that smoking continues to be the leading cause of preventable death and disease. And, the real problem we're trying to solve is the fact that of the 40 million smokers in America, half of them will try to quit this year. And the number one way in 2023 that those smokers try to quit remains cold turkey, because the therapies that are available to them really are not effective at helping address all of the challenges of the addiction behavioral aspects, the physiological aspects that they struggle with. And so our therapy, we believe, really represents a potential breakthrough to help those smokers quit more effectively.
Right. I've been amazed personally, as a physician working in the hospital, of the devastating long-term effects of cigarettes. Everyone knows, I think, that cigarette smoking can cause lung cancer, right? That's pretty well established. I think that's out there in the community. And I think the Marlboro Man even succumbed, to lung cancer, kind of ironically. But cigarette smoking has effects on blood vessels throughout the body. And so we see premature heart attacks. It's a risk factor for stroke. I'm a neurologist, so we see a lot of strokes due to smoke. And of course, it's hard to undo if you've had, I just smoke a pack a day, but we talk in pack years. Well, for the last 30 years, 40 years, I smoke, 1 to 2 packs a day. So that's 50, 60, 70 pack, years. Well, that all adds up, and the blood vessels really don't like all that smoke, plus the 1,000 other chemicals or so that are in cigarettes. So just, the real question is, why do people start smoking in the first place, right? And it's just kind of mysterious why there are still cigarette companies making these things.
Yeah,
Yeah, tell me.
Well, I mean, I can't answer why do people start smoking, but it is really fascinating. I think the entire challenge that exists in the space. I think there's also a lot of misconceptions. A lot of the times you hear about, oh, the reductions in incidence of smoking, and people in public health hold that up as a sign that regulations, higher prices, and taxation are having an effect. But the reality is, what people are missing is, well, the population has grown. So even though incidence of smoking has come down over the last 20 years, for the last around the same 15 to 20 years, the absolute number of smokers in the US has remained relatively constant at 40 million. So, to me, I think there really two things have to happen. There has to be a continued push for more regulation, and we're seeing that now with FDA proposing things like menthol bans. Obviously, there was a nicotine standard proposed, which I think we'll see how that plays out. But those regulations will really not have the intended effect unless, from a broader policy perspective, there are truly effective therapies to help those smokers quit. It's not just making the products more expensive, because to your point, when you have addiction behavior, people will pay the price, physically and out of their pocket, to buy those products. And so, for those increased regulations to have the effect, there has to be a portfolio of medically safe and proven effective cessation therapies beyond what's available to those smokers today. So when those products get pulled off the market, or as those regulations get passed, there's an off ramp for those smokers to break the chains of addiction. And that's what we're focused on trying to help accomplish. And that's how we really will make big progress as a society of reducing the death and disease, and hopefully eliminating the death and disease caused by smoking.
Okay, so tell me more about Qnovia and what is this product that it's not FDA approved yet, right? But the goal is to make it an FDA approved prescription treatment for people who literally are addicted to nicotine through cigarettes. Is that correct?
No, that is correct. So a little bit more about the product itself. What we're doing and what's unique is we have an underlying technology to deliver a medically safe aerosol that can be inhaled. And this is indeed a nicotine replacement therapy, right? So today, those nicotine replacement therapies are the gums and the patches that deliver lower levels of nicotine that smokers use to help deal with their withdrawal symptoms and titrate their use over time to ultimately stop smoking and stop using nicotine altogether. But what's really novel and unique is this. What I'm holding here, this is a vibrating mesh nebulizer. This is a medically safe and designed cartridge, which has a vibrating mesh nebulizer, which is a proven medical technology for delivering drugs to the lung. And it contains our proprietary drug product formulation, which does contain nicotine. But this is plugged into a base unit with software and hardware that is programmed to titrate a user's exposure and use over 12 weeks to really help them make that transition away from cigarettes and then ultimately reduce their dependence. And because this is inhaled, when this is inserted in the base unit, you're also not only delivering the physiological aspects of to alleviate the withdrawal symptoms, you're dealing with hand to mouth action, and this actually can replace the occasions that a smoker is used to. A lot of smokers, when you talk to them when they're trying to quit, they say, my problem is I put a patch on, but I'm used to, my first cigarette of the day is when I have my cup of coffee. And so the patch is giving a very low level of nicotine, but not enough to deal with their withdrawal symptoms. But then from a behavioral aspect, when they start drinking their coffee in the morning, their brain is triggering for, wait a second, this is when I get my nicotine. And now, because we have a technology that allows that patient to take that dose exactly when they need it, they're dealing with both the physiological and the behavioral aspects. And this technology, one can meet FDA CEDAR's, safety standards and efficacy standards. And because we're delivering the drug, in this case nicotine, to the lung, the pharmacokinetics are such that we will still be delivering to the patient less nicotine than they had in a cigarette, but more than they get in a gum or patch. So then they actually have a fighting chance to break through, on their own, those last couple of steps of fighting through their withdrawal symptoms.
So it's more of a peak and trough. When you take a suck on this thing, you're going to get some nicotine, right?
Correct.
Into your lungs. And it's monitored, it's titrated. So over time, each time you do that, you get a little bit less and a little bit less. But you won't feel it in the sense you're going to get the same amount of air nebulized coming in. It will just have less nicotine in it. Is that right?
Yeah. In essence, how it's delivered is through a reduction in the available doses. So the device itself is programmed. So for a pack-a-day smoker who starts this therapy, when they go to their doctor and they get their initial prescription, the doctor will start them with 20 doses in a day to replace their 20 cigarettes. And then the device is programmed over the 12-week prescribed use regimen. The device itself will reduce the number of doses that they can use during the day. So then ultimately they can get to 19 to 18 to 17. At the end of the 12 weeks, their dependence to nicotine is diminished to the point that they can take that last step and become nicotine free.
So you only get the 20 doses and then that's it. It runs out.
Yeah, and the device has safety controls, so the patient can't use more than the prescribed dose. And as you mentioned earlier, we're not yet approved by the FDA, but in our discussions with FDA, that is really important. Is how do we ensure that there's controls and protections? So because again, this is delivering nicotine, that we're minimizing any abuse liability potentials while achieving the main goal, which is having someone who is just dealing with this burden and the struggle of their addiction put down their pack of cigarettes and work their way through the cycle that's required to break their addiction to nicotine.
Okay. So let me ask you another question. I know there's this thing, and I don't know much about it, called vaping, right? Tell me just quickly, what is vaping and how is your gadget different?
Yeah, no, it's a great question. So, vaping or use of an e-cigarette was a technology that came to the market, back in 2015 or 2016, as a tobacco product. And, those products are, first of all, are regulated like a tobacco product by the Center for Tobacco Products at FDA. And technologically speaking, what they do is they use a heating element, either a coil or a ceramic heater, to heat a liquid, which is then an aerosol, which is inhaled by a smoker. Now, those products are marketed as potentially replacements to cigarettes, and there's been a lot of conversation in the science about what's called the relative risk of those products, because I do think there is a lot of data that would say at an individual level, those products do have fewer carcinogens than a cigarette. And in engaging with FDA, those tobacco companies and e-cigarette companies tell FDA that this is a way to reduce the harm associated with smoking. But there's really kind of two problems with that. Actually, there's more than two. The first one we all experienced, which was some of those products came to the market and were marketed, irresponsibly, and we ended up with a youth usage epidemic, right, where millions of kids got access to these products and became addicted to nicotine. So that's bad. In addition, those products, because they use a heating element and the ingredients they use are not designed to be, medically safe, the user is still exposing themselves to carcinogens, although maybe less than in a cigarette, but they're still being exposed to carcinogens. And I think there's a lot of confusion about that. And the last piece is, because of those two things, really, and because of the lack of innovation of cessation therapies, those are kind of the products that are marketed as an alternative to smoker today, but they're not safe. And tobacco companies will tell you there is no safe tobacco product. So again, what's different about our technology is we have a formulation that's designed to be medically safe and a technology that delivers nicotine to the patient in a very controlled manner and frankly needs to be controlled, prescribed, and monitored like medicine. And so those are the real differences with our technology versus what people see as they talk about vapes or e-cigarettes.
Okay, that's very, very helpful. Now, to understand your, it sounds to me like your technology is basically a souped up computerized asthma inhaler. Um, I mean, that's right. You're just taking
That's
a big breath of an active ingredient, but it's going to monitor it. It's going to titrate it over time. It's going to record it, but you're not getting any smoke, right? There's no
correct.
smoke. You're just getting mist plus nicotine, right?
That's correct. And part of the challenge is, if you think about, the delivery of pharmaceutical ingredients to the body, we're not delivering that buccally. We're delivering a particle size with aerosol characteristics to deliver that drug into the alveolar region of the lung, which is how we will, believe we'll have better efficacy outcomes versus nicotine replacement therapies like patches and gums.
And I'm not saying you would recommend this, but I don't see a reason why it couldn't be used in addition to patches and gums if there was an indication to do so.
Well, and again, it's a great question and really something that we would have to adjudicate with FDA. I mean, obviously, our clinical plans, first and foremost, are really designed to, we have a comparator product that we compare to that is an existing approved prescription NRT. And other over-the-counter therapies is to demonstrate the safety and efficacy relative to those therapies. But in the world of smoking cessation therapy, and actually in practice, you see that tobacco addiction specialists. There's a lot of work in the research arena around how do you couple all the existing therapies together. What's the right intervention point? What is the right cessation support emotionally that people need to have better outcomes. But for us, really, it starts first and foremost with we're kind of following the path paved by previous nicotine replacement therapies, so proving efficacy alone. And the existing therapies, the efficacy is somewhere between 4 to 7%. Our goal is to have dramatically higher efficacy rates alone, and then really doctors can make those decisions with their patients to say what is the right combination of therapies and support that their patient needs to be successful and ultimately quitting.
Now, is efficacy defined as the percentage of people who want to stop smoking, use your device, and then stop smoking for ever, or 6 months, or however long you guys could afford to continue the study? How did that work?
Yeah, so ultimately, the endpoints are what you described. So, is the number of patients that complete the 12-week therapy. At the end of 12 weeks, then there is a monitoring process to using both CO2 as a biomarker and self-reported abstinence to demonstrate that they have stayed tobacco-free at the end of the 12 weeks, and then also with reads out to 24 weeks and potentially further post the end of the study. How long that kind of post-study monitoring stays in place will be something we finalize with FDA before we begin our phase 3 human clinical. But you do need to demonstrate that there's abstinence post that therapy, and CO2 monitoring is the biomarker that FDA looks for there.
Explain that, CO2. I thought carbon monoxide went up, but CO2, carbon dioxide, is
Oh,
also
no, see, I'm not the scientist. You're right. It is carbon monoxide, not carbon dioxide, is the biomarker. But you are correct, because when you smoke a cigarette, that does affect the carbon monoxide levels, as you exhale.
right. And if there are any non-medical people watching, carbon monoxide's bad. That's what you breathe in when your house burns down and you end up in a coma at the hospital. So just voluntarily, sucking in carbon monoxide just doesn't really seem to be the ideal way to start your
Right.
day from at least a health point of view. So when you guys were brainstorming this, because one of the things we've hinted at, that addition to the physiologic dependence on nicotine. There is a psychological addiction that goes along with, as you say, having a cup of coffee. Well, what happens next? Or stepping outside for a coffee break or a cigarette break, right? Everybody knows it used to be something called the cigarette break. I'm going to go have a cigarette break until they said you can't smoke anymore in the office. And, you find people a block away on the corner, right? There's still a few holdouts. So, did anybody talk about, well, let's make this thing look like a cigarette? Could you do that? You know?
So actually, we're really guided by what patients, what do patients want and need to want to use this therapy once it's approved and to stick with it. And actually, what's really interesting from the patient perspective, they want this to look very different than a
Ah,
cigarette because if you put yourself in their shoes, and you're in your job and used to take your smoke breaks, well, you need to be able to use this
mm,
in your office, and you need to be able to tell your boss, hey, I'm not vaping, this is my medicine, right? So the device itself, what they want is they want to be handheld and portable, but they also want to be clearly distinguishable from the analogs that exist today, whether it be e-cigarettes or cigarettes, because they don't want to be branded as a smoker. They don't want to be branded as a vapor. They want to be confident in themselves, and they want to be able to tell their friends, their colleagues at work, their bosses, hey, this is my medicine, and this is what's helping me stop smoking. So really, that's all part of our human factors work we do with patients, and in the design of the device. The device has an LED screen that reinforces key information to the patient throughout the day. How many doses do you have left? It can give them, it tracks and stores all the data through the entire 12 weeks. So on day 7, you'll get a message on your device saying, great job, you're 1 week,
mm.
smoke free. All of those factors are really driven by, the research of the patient and what is the patient looking for to have this therapy, be something they can use and stick with for the full 12 weeks.
Where are you now in the FDA approval process?
Yeah. So currently, we're advancing to what's called our IND submission, which we will make later this year. And then from that, we will begin our human clinical studies. So we have to run through a phase 1, 2, and 3 study plan with FDA, which was mapped out in our what's called our pre-IND engagements. And our goal is that we'll be in a position to submit our NDA with our pivotal clinical data in 2025.
Okay, so a good 2 years of finding patients and implementing protocols. How many patients ideally do you have for phase 3? How many patients ideally would use this device, I guess, versus a placebo
Yeah.
device, or
Yeah,
however you're going to do it?
500 is in our discussions with FDA to date has been the target for that phase 3 pivotal, 500 subjects in the kind of test in the control arms.
Well, there's plenty of smokers out there, so it may be hard to find the control subjects. Well, I guess all of the subjects would be smokers, right? And some would get placebo, and some would get the active ingredient.
Correct.
You don't really need healthy people. Wow. Well, good luck. I mean, 2025 could have a new gadget. You Bluetooth it to your phone. It's like, oops, you missed a day. No more cigarettes for you. And how often do patients in this 12 weeks, will they come in for carbon monoxide monitoring at any point, just to kind of double check what's going on with them?
In the clinical study or in practical use?
I guess in the clinical study, because you want to make sure that they're not cheating,
Right.
right?
Well, in the clinical study, there will be monitoring throughout the 12 weeks as well to ensure that the self-reported abstinence is also being evaluated with biomarkers. So that will be part of the entire clinical plan through the use as well.
Sounds exciting. Brian, is there anything you'd like to add before we wrap up?
No, I mean, I think the only thing I'd like to add is kind of where we started, which is, we're just one company in this space, and from the perspective of trying to end the world's leading cause of preventable death and disease, I think what's really important is, we as a society and policymakers broadly need to not only focus on what are the new regulations, right, on tobacco products to make them less accessible, to inform people of the risks and make sure people don't pick those products up. But we need to have an environment, not just from companies like Qnovia, but also other companies, to be developing those therapies to help those patients stop. And that's really the gaping hole, right? There hasn't been an innovation since in the last 15 years in the space. And I think that's a failure on all of us. So my hope is that not only our company, but lots of companies will really make this their mission, because that's how we'll solve the problem.
Sounds very promising. Brian Quigley, thanks for joining me on The Art of Medicine. I'm Dr. Andrew Wilner. See you next time. Before we close, I'd like to give another thanks to our sponsor, locumstory.com, a resource where providers can get real, unbiased answers about locum tenens. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com